Well, hello, and thank you so much, Anne and Dr. Mack, for having that conversation. Really, I can just reinforce how great it was to work with the PCC team and how excited we are to be able to release this report. I'll just say one of the things that I'm most excited about the conversations that we had, the work that we put into developing the report, really is seeing health equity prioritized. And that's what we have talked about for so many years, about the prioritization and the will to act and center equity. We've talked all morning and you've heard all morning just why primary care is such a fundamental piece of the health equity conversation. And I think the report says a lot about it, and I'm really excited about our upcoming panel because they're going to do a little bit deeper dive and provide some really specific examples of how health equity and primary care go together in practice, and how the federal government is thinking about that and acting on that, even more importantly. So I am very happy to introduce our panelists today and have the pleasure of moderating the discussion. Our first panelist is Dr. Judith Steinberg, Senior Advisor to the Assistant Secretary for Health and lead for the Department of Health and Human Services Initiative to Strengthen Primary Health Care. Dr. Steinberg has served as the Chief Medical Officer for the Bureau of Primary Health Care, which is part of the Health Resources and Services Administration. She focused on integration of behavioral health and primary care as a response to the opioid epidemic. And she has also served as the CMO for the Office of Infectious Disease and HIV/AIDS Policy. Advancing health equity and reducing health disparities have been major focus areas for all of these efforts. Our second panelist is Mr. Benjamin Money, Senior Vice President for Public Health Priorities with the National Association of Community Health Centers, where he leads collaborations with public health as the executive lead for social drivers of health, value-based care transformation, and the environmental health initiatives. And prior to joining NAC, Mr. Money was the Deputy Secretary for Health Services at the North Carolina Department of Health and Human Services, where he led the divisions of public health, health services regulation, and the offices of rural health and minority health. And I'll just add a quick aside there that we had the opportunity to work with him in our digital health tools study and the primary care clinicians in the state of North Carolina. Our third panelist is Dr. Kameron Lee Matthews, Chief Health Officer for City Block Health, a transformative value-based healthcare provider integrating medical, behavioral, and social services for Medicaid and dually eligible and low-income Medicare beneficiaries. Dr. Matthews is a family physician who has focused her career on underserved and vulnerable communities and has held multiple leadership roles in correctional medicine, federally qualified health centers, and managed care. So welcome everyone to the panel. And I would love to just start the conversation hearing from you with a brief overview of your current role, your organization, and really from that perspective of strengthening primary care and specifically advancing health equity. Give us a little bit more of a background. Ben, do you mind starting us off?
Sure, Megan, and thank you so much for the opportunity to share the perspective of community health centers on this important topic. It's an honor and a pleasure to participate in this Health Equity Summit. Morehouse School of Medicine and the National Center for Primary Care have been longstanding, reliable partners to community health centers, and we're grateful for your support. So community health centers, also known as federally qualified health centers or FQHCs, are the medical home for over 28 million people in all 50 states and territories. They're the largest primary care network in the nation, providing integrated medical, pharmacy, behavioral health, dental, and supportive services, with over 1,400 organizations operating over 16,000 clinical sites. Health centers by statute must be located in medically underserved and health professional shortage areas. And health centers provide culturally and linguistically appropriate services. They also strive to hire providers that reflect the demographics of communities they serve. And health centers provide care to anyone, regardless of their ability to pay or insurance status, through sliding fee discounts for services. And most importantly, health centers are governed by an independent patient majority board of directors. So just a few demographics: 92% of health center patients live below 200% of federal poverty level. Health centers also serve 1 in 6 Medicaid beneficiaries. The patient panels have a greater incidence of chronic disease. 1.3 million health center patients are diagnosed with asthma, 2.7 diagnosed with diabetes, 5 million with hypertension, and 2.6 million diagnosed with depression, 2.7 with anxiety disorders. It's also important to note that over 58% of health center patients identify as racial or ethnic minorities. In the United States, discriminatory redlining has forced Black and Brown people to less desirable areas of communities where highways, manufacturing plants emit toxic particulate matter, and urban heat islands put them at higher risk for environmental harm. So it's my focus at NAC, and the focus of my division, is on the 50% of health impacts that happen outside of the clinical setting, those social drivers of health and environmental health factors, including climate change, that are threatening our communities. It's a real pleasure to be here, and I look forward to the discussion in this panel.
Wonderful. Thank you so much. Kameron.
I'm so excited for this conversation. Thank you, Megan. Hello, Judith and Ben. This is a fun conversation to join from CityBlock. I am really proud to be with this organization most recently since January, and just learning so much about honestly, a space that I think we're well suited to occupy. I, of course, came from my time prior in VA, and I'll say the transition, while definitely special from government to startup world, right, has been fun. I think part of where I see the real ability to traverse these different worlds is that in the VA, of course, we really had a concept of whole person care, right? That we're able to take care of a person, not just based on an encounter and a visit, and it's not just about what we are billing for that individual veteran, but we really cared and had a mission, and therefore we're able to operationalize the full ability to take care of that veteran from the time of their detachment from service, even actually past death, as we were able to bury them with the respect that they deserved, right? So now coming to CityBlock, a very different space, obviously, focused on Medicaid and dual eligible communities. We are able to do the same approach to our patients. I'll say it like that we are able to, through a very different business model, a very different payment model, we're able to take care of that whole person. So yes, we're a startup. Yes, just through the last 5 years, have really been able to stake a place across multiple markets now as a value-based healthcare provider with the ability to make an impact, again, through Medicaid programs, dual eligible programs, which in and of itself encapsulates so much of what we need to talk about today as far as health equity. These are communities that are obviously facing significant and overlapping complex needs. Let's not even then strive to forget how important that overlap with their behavioral health needs are, as well as their social care needs. And we see ourselves as truly an integrated provider of not only all of the above, but also the care management and the navigation that our members need between all of those services. We really do emphasize, not only for our members, the people that we serve, equity and access to care when and where and how they need it. But we also emphasize the same sort of approach to equity within our own workforce. It is quite a necessary part of our model that we have members of the team, including their community health partners, as we call them, who are from the communities which these members serve, very much in line, as Ben described, with FQHCs. We need this workforce to reflect the people that we serve. Our members need to feel respected in every way, not only by our own care teams, but the health system as a whole. Engagement with us alone is not sufficient, nor is it with any clinic, practice, hospital out there. We are all lumped together in their minds, right? Healthcare services are along a spectrum for them, as opposed to this very encounter-based way that the rest of the healthcare system tends to think of itself. And so we do as much as possible to really bring down those walls and help members no matter where they are and what services they're receiving. So part of our model, again, value-based is that we're not really focused on that fee-for-service approach. It's not about visits. I'm not worried about productivity for my physicians, my nurse practitioners, my care teams as a whole. Because we're in this different space financially, we're able to explore a much broader sense of services that we're able to provide and really focus on their social needs, which of course maps completely to the health equity concerns, and actually do something about it, not just measure it, not just write it down in a chart, not just acknowledge and refer out, but actually have our community health partners take on action to connect our members to those services. One of the biggest efforts that we have and why we're such a strength to our partners is because we truly acknowledge and strive to intervene along the concepts of trust and engagement with our members. It is not sufficient to just have them walk in our doors, wait for them to come to us. We actually do everything possible to go to them. We are responsible for them. This is what the risk incentive sets up in our business model. We are responsible for them, whether they are in front of us or not. And so therefore, as a system, we are completely incentivized to go find them. I actually have examples of some of our members being met on park benches because that was the only place we could engage with them. That was the one place that they felt they could trust and connect with someone new. And that's just what we're going to do. That's not easily allowed in a different fee-for-service world. So I think just the ability for us to understand value, to really be able to direct resources to the members' needs, while also providing high-quality primary care, integrated behavioral health, I think is really the strength in how we're actually going to make an impact from a health equity concern.
Absolutely. Thank you so much. And Judy, would love to hear a little bit more about the work that you're doing at HHS.
Well, thank you so much, and good afternoon, everyone. And thank you so much. It's really an honor and a pleasure to be here to talk about such an important topic. So I am a primary care internist and infectious disease physician, and I practiced in community health centers for my whole career. So what I wanted to share with you is about the initiative to strengthen primary health care. Just give you a quick overview. It is an HHS-wide initiative. It was launched in recognition of the need to have a strong primary health care foundation to achieve the goals of the Biden-Harris administration and HHS. And they are improving access to health care, improving the health of people, families, and communities, and improving health equity. And our first task is to develop an initial HHS plan to strengthen primary health care, recognizing that this is not like flipping a switch. Subsequent plans will be needed using a phased approach to get us from the current state of primary health care to a defined goal state. And our goal state is very similar to the NASM report's primary care report. It's about having equitable access to comprehensive whole person health care delivered by interprofessional teams and through partnerships so that we can meet the health and wellness needs of people, families, and communities. And integration, just as Kameron was mentioning, integration of services is a key facet of this model, of this goal state. And that means integration with primary health care of behavioral health, oral health, public health. So the question is, how do we achieve this? And what we're doing is we're working with all the HHS agencies to develop this plan. And we're using the NASM Primary Care Report Implementation Plan as a guide. So that means that the HHS plan will have actions in each of the 5 domains of change that were recommended in the NASM report: change in payment, access, workforce, digital health, and research and accountability. We're also reaching out to and hearing from non-federal external stakeholders and partners. At last counted, over 80 partners that we've spoken with, including patient, family, and community advocates, so that we can better understand the needs and challenges, and also the innovations that are already in place or in design to address problems and barriers. All of this is to inform the HHS plan. And I wanted to let you know about a request for information that's coming out soon, so where we're aiming to open the opportunity to provide input into the HHS plan from a broader and more diverse group. Ultimately, we aim to develop this initial plan and present it to Secretary Becerra by the end of September. And I also want to follow on from something Ann Greiner mentioned about the need for that coalition. The HHS plans for strengthening primary health care really aim to provide a federal foundation for strengthened primary health care. The federal government does play an important role in shaping primary health care, but it is not the only actor. And strengthening primary health care requires really an all of society approach. We need actions taken by many, by healthcare payers and providers and purchasers, employers, communities and patients and families, advocates, state and local and tribal governments and public health departments, academia, professional societies, and it goes on. So that coalition is going to be very, very important. So let me stop there and we can move on. Thank you.
Thank you so much. And it's so exciting to hear about that work, again, from the side of hearing health equity being a priority. One of the few that you listed there as the priority. And then also thank you for highlighting an action step, public comment process, not always the most well-known or easy mechanisms, but a really useful way for communities, clinicians, everyone to really respond and react to government proposals. So thank you for that. I want to start out this conversation, and then I do want to reinforce that I'm hoping that this really will be a conversation. So where you hear one of your colleagues say something that you want to respond to, feel free to jump right into that conversation. But want to start out with, especially Kameron and Ben, you mentioned several activities that you do to advance health equity, specifically the patient advisory boards, community health partners, addressing social needs. We talked and heard a lot about the payment needs and kind of payment structure, but can you start the conversation with some of the activities, initiatives that you all do in your organizations that other primary care settings can potentially apply and learn from, regardless of the payment structure? Ben, do you want to start off with that?
Yeah, I sure will. And just for a little bit of background, health centers have a unique payment model that's statutorily required. It's called the federally qualified health center prospective payment system. And it was really based on Congress's realization that health centers need a Medicaid per visit payment rate floor to guard against them from having to divert their grant funds, which are intended for the uninsured, to cover the cost of seeing Medicaid patients. So rather than being paid fee for service, FQHCs receive a single bundled rate for each qualifying patient visit. And this single rate pays for all covered services and supplies provided during the visit. So it's not a value-based care model, but it's on the path towards value-based care. I think it's important to note that simply converting a PPS to a value-based care rate is not going to be sufficient. It's just not going to cover the costs required for those non-reimbursable processes, the staff, the care coordination, the community health workers, and the investment in program development. It's also important to note that updates to PPS rates have not kept pace with inflation or with changes in the range of services health centers need to provide. So on average, PPS covers about 80% of a health center's costs of caring for Medicaid patients. It's, again, important to remember that health centers have to see anyone, regardless of their ability to pay, and they can't deny care to Medicaid beneficiaries, even if the payment is less than the cost. So, when I think about what health centers do that can be instructive and informative to other primary care providers, recognizing the fact that obviously health centers have these federal mandates. But I think the patient governance of health centers really is at the essence of what makes a community health center unique. It's ownership within the community. It truly is consumer-driven healthcare. And so also as nonprofit organizations, health centers take any savings that accrue, and that could be savings in value-based care payment models where there are incentive bonuses or performance bonuses. They take those savings and they reinvest them back into care. Same is true with the 340B pharmacy discount program. Those discounts are applied to reducing the cost of patient costs for pharmaceuticals, as well as developing programs to support patient care. Again, reinvestment back in the community. And so I think the other lesson that can be learned from our approach in working directly with the consumers or recipients of care that we provide is that the community can really be co-creators of solutions, and that we need to engage our communities. They know intimately what the issues are, what the barriers are, what the motivators are, and have solutions that need to be developed in conjunction with care providers, in conjunction with local government and healthcare partners to really get at addressing health equity. And the other thing I will say too is that you can identify any community health center's performance by going to the Bureau of Primary Health Care's website. The Uniform Data System report is publicly accessible. It's updated every August. And on a state-by-state basis, you can pull down an individual's health center's report. So that's transparency, that's accountability. And I think it goes a long way to really demonstrating the progress that needs to be made in terms of achieving health equity at a population level.
Thank you so much. Kameron.
Yeah, I absolutely love the FQHC model and remember it quite fondly, miss it every day, and am really proud that our nation has this capacity. I think we need to expand it more. I think the way that we, of course, differentiate ourselves at City Block is I think we have, just through our alternative payment structure, I think we've been able to think outside of the box more as far as some of the interventions that we've really been able to pull into our care model. Because I think, unfortunately, even within the kind of standing advanced sort of payments that FQHCs get, I remember fondly, unfortunately, maybe not fondly is the wrong word, it's really difficult to step into the kind of less traditional care models at times, right? And some of that may be just kind of resistance. It may not be that financially that's the end result, but I think for us, we've been able to think outside of the box with our community health partners, really having them even at the lead of the care teams. It's not so much about provider billable visits. In fact, it's not visit-based whatsoever as far as an encounter. I think the fact that we've been able to really expand the services that we provide in the home, even up to ED visits. We actually employ emergency room physicians who are on an iPad, and the EMTs are actually in the home, of course, already screening the things that needs to go to an actual emergency department, but we know that a significant portion of that care can occur in a home environment. We can address their needs and really able to then turn that into a continuity relationship and get them connected to their longitudinal team because we are all, of course, in the same practice. I think our ability to then really connect with our members cross providers, meaning throughout our network, our inpatient discharges, our ED visit discharges. We actually send our teams to case conferences with those hospitals to help manage where they're actually going to be discharged to, whether it's the home or the SNF, or maybe it's something we can take on that they traditionally would have sent to that SNF, because we have the ability to do perhaps some wound care or even some infusions. We've also been using our home-based services to initiate a great deal of behavioral health therapy. So separate from kind of the counseling and the virtual services, doing long-acting injectables in the home, initiating medication-assisted therapy for substance use disorder in the home. These are all addressing barriers that a lot of our members face as far as just transportation, trust of being able to walk into these facilities, because we've approached that, because we're part of their care team and we're bringing the services directly to them. I think that's addressing a need that we are definitely getting the feedback is unfortunately not available in other parts of the system. I hope, honestly, that we become more person focused, customer focused. I don't think right now our system allows us. I know FQHCs around the country want to do exactly the same work that we're doing in City Block. It's not due to lack of desire or intent. I really do believe it's the structure of our system and a great deal of the payment model that restricts our abilities to truly meet our patients where they are.
Yeah, it's really interesting that you mentioned that, Kameron, because when I first learned of City Block, what came to my mind is, wow, if we were to take the health center concept and sort of move it to 2020, right? How would we design it? Obviously, we would continue with that patient governance and that level of engagement, but having those patient engagement representatives interact with people as kind of that point of contact, I think is a novel and I think, quite frankly, replicable approach when we consider value-based care, right?
Yeah.
Think about the pandemic. Everyone that we serve was impacted by the pandemic.
Exactly.
There's latent stress, anxiety, depression, loss, grief, on and on and on. Behavioral health needs to be embedded in everything we do. And you do that at City Block. You do that. And also just this innovative use of technology, right? Thinking about building technology from the ground up, rather than have it based on how do we satisfy a claim, how do we satisfy this fee-for-service, encounter-based, episodic approach, rather than a longitudinal approach, an electronic health record that really has a longitudinal focus that takes in data from all sources and is built for the care team's use, not to generate a claim. Right? And then think about using technology in the modern sense, right? With, like you said, iPads and text messages and how people communicate now. Being able to give people that 24/7 access, I think that is really unique. I was chatting with a friend of mine that is one of the medical directors for City Block, and she was really raving about the community paramedic program. And I think that is really a novel way of being able to extend care into the home, but it also creates these pathways for community health workers to advance either directly in a community health worker career or, a track that takes it more towards medicine. The other thing is just that intentional integration of social drivers of health. I was actually revisiting the video Out in the Rural from 1967 with Jack Geiger and John Hatch, and really looking at that original model in Mount Bayou, Mississippi. And so much of what they did was focused on social drivers of health. I mean, that was what it was all about, right? And engaging with the community. And I think over time, what's happened is the health center program has gotten very primary care focused from a medical standpoint, recognizing the fact that 50% of things that impact patients' health happen outside of the clinic walls. And so I think you guys have been able to sort of take a blank piece of paper, a fresh approach and be able to map out how to design, an intervention really, I think, for the 21st century.
Ben, we're gonna flip your background there, and I'm gonna bring you on my team. Like, my goodness, thank you for that. I didn't even jump on the technology piece, but I truly, and Judith, I'm hoping as well that in HHS there's as much emphasis. I think our approaches to technology and data are so critical in the primary care space, in the health equity space. We really need to get away from these EHRs, exactly as Ben said, that are so focused on claims. Yeah. We need to be looking at provider and patient-generated data more appropriately. We need to be obviously looking at data across health system and bring down these walls of privacy, of course, keeping patient privacy into concern, but the privacy between health systems, those walls need to be brought down. Just kind of the proprietary nature of how data is treated is keeping us from really addressing these population level concerns. And we're doing our part in City Block, but we still have to interact with the rest of the health system, and that's a difficulty, right?
Right.
Well, thank you. That covered so many of the questions that we're going to be coming up throughout the discussion. And I know, Judy, that gave you a lot to work with. Yes. I also want to recognize that, where you are and where the federal government is in the process, and what you have already figured out and what still needs to be figured out. But hearing some of those payment and transformation and innovation technology points, we have these models that are doing such innovative things. How are you thinking about that in your role? How do you turn that into what can be done at the federal level?
Okay, thank you. And thanks to my colleagues for their enthusiastic support for the what primary care really can bring, support and action. First of all, we've heard, I think, really well from that PCC-NCPC report about how primary care can advance health equity. And here we have some great examples of primary care practice models in the FQHC and with City Block that can accomplish it. Yes, the FQHC is, the concept behind the prospective payment was to pay for all the comprehensive services. Unfortunately, it's been underpaid. And with City Block, what you have is the increased and upfront investment in primary health care that lends you the flexibility to be creative to fully meet the needs of individuals. So that's why when we think about how do we take these models and scale them up, what are the key factors? Well, clearly one of the key factors is the payment, right? So that is going to be a focus of the HHS plan. And so that we have that kind of upfront investment and flexibility to meet people's needs. Of course, then we also need to have the workforce to make this happen. And adequate payment, I would argue, is also a critical factor for that as well. So, but I do want to underscore in terms of primary care and health equity, something that Anne and Dominic had mentioned, that primary health care can't do it all, right? As far as improving health equity. It can't fix long-standing systemic inequities and structural racism. But the approach that we're taking with the HHS plan is that with making changes in different policy arenas and hopefully with more investment and with interprofessional teams, primary health care can work in partnership with communities to be comprehensive in its approach to addressing social needs of people, including the social needs, by referring for services and closing the loop with good communication and coordination. And it can be culturally and linguistically sensitive and competent, informed and governed by the people served. And services can be provided at times and through modalities that, such as telehealth, that recognize the needs and lives of the people we're caring for. It can also be cognizant of implicit bias and address this. So And then we do need to increase the diversity of the workforce, as Kameron mentioned. There are federal and state levers for this, but there are also actions to be taken not only by the primary healthcare practices, but also in communities, school districts, educational institutions, thinking about the pipeline. And also primary care can measure access to care and services, as well as outcomes stratified by race, ethnicity, sexual orientation and gender identity, and other demographic factors, and then monitor disparities and then make continuous improvement in its care delivery to reduce them. So there's a lot to be thinking about in terms of what primary healthcare can do to advance health equity. And that brings us to how we're approaching that in the HHS plan. So as I mentioned, improving health equity is a goal of the administration and HHS. And it's a guiding principle for the actions that we are proposing to take in each of the domains for change. So that means that in our approach for developing the HHS plan and in choosing actions, we are using a health equity lens. And also we need to assess the potential impact of the actions that we're considering, as well as unintended consequences. So that's the approach that we're taking. And we also recognize the importance of measurement, including the collecting data on race, ethnicity, and other demographics, and monitoring health equity through a primary healthcare dashboard. So that's our approach.
That's really great. And just hearing so many of the points throughout the day and things that we've been working on for so many years coming to fruition, hopefully. So really appreciate that. I just want to remind the audience, we are coming down to about the last 7 or 8 minutes of this panel. If you have any questions, please feel free to put them in the Q&A, and we will hopefully have time to take 1 or 2 of those. Before we get there, I really wanted to dig in a little bit more to the technology piece. We mentioned it a little bit, mentioned some of the issues with interoperability and data sharing. I think Kameron, Ben, you both talked about some of the analytics and how you can use data to really inform decisions, make connections outside of the clinical walls, address social needs. With all of the issues of technology and digital tools and access and digital literacy, where do you think the kind of biggest focus or where's the biggest need for primary care settings to be able to really harness that potential and leverage the data and technology that exists across the health system? And that question can go to any of the panelists.
I think for me, the broader concept of interoperability and data sharing is such a critical piece, while of course we're able to address the needs of our patients within our own practices. If we're not tracking what's occurring in other geographies, other emergency departments, inpatient, the fact that we're still, sending out requests for records and getting them in paper fashion and needing how to translate them into our own systems is just wholly inefficient. It takes away from our ability to manage our patients in a timely manner. I really do think, again, we need to kind of bring down those silos of data and have a broader sense of connectivity within the healthcare system before we can turn to anything that's more patient facing. I mean, of course, a lot of that data needs to become more readily available directly to the patients, whether it's through a portal or some other ease of access. I think that's equally as critical. But from a just sheer operational standpoint, the lack of data sharing is definitely something that unfortunately I think sets us up for some difficult dynamics that I think is easily addressable if we're looking at more interoperable nature of not only the EHRs, but the data transmitted between them.
Yeah. So we're thinking, and for the HHS plan, we're thinking about the federal levers that we have. such as through the Office of the National Coordinator for HIT and also other HHS agencies to improve data interoperability. So we get it, that in order for primary healthcare teams and their partners in specialty care and behavioral health and community-based social service organizations, for example, they need to have the data to be able to provide comprehensive services and coordinate care. So we're also considering the federal levers to improve the electronic health record standards so that the EHR is a facilitator and not a detractor on the desired primary health care. And so that means for the EHR to have the ability or the functionality to include valuable clinical decision supports and registries, patient-reported data, and also the ability to collect data on race, ethnicity, sexual orientation, gender identity, and other demographic data in the electronic health record, and also to improve patient portals. And then lastly, in terms of federal levers, we could be providing more support for technical assistance to primary healthcare clinicians and their teams, as well as patient education on these digital health devices, the software, and apps. So that's how we are approaching it in the digital health domain.
Thank you. And I'll just add, we did get a question from the audience that is relevant to this question. I think a really important aspect to be thinking about, where the interfaces, the algorithms that we know are problematic and potentially have bias baked into them.
Yes.
You know, how are each of you and how are you thinking about that? How do we address that with the technology?
I would just go back to something I said about how health equity is our guiding principle. So we do need to be thinking about the actions and what is the impact of the actions and the unintended consequences. So that is an important approach.
Mm-hmm. And one of the things that Kameron mentioned earlier, and Judy alluded to when you discussed the Office of National Coordinator, is just the problem that data blocking makes for primary care providers to be able to have the type of view of what's taking place with that patient outside of their clinic, to be able to comfortably enter into value-based arrangements, particularly any that incorporate any downside risk. They've got to be able to see that full spectrum of impacts on that patient. And, you know, I was pleased to hear about the focus around developing electronic health records that really are provider and patient centric. Having those analytics tools baked in is essential, because right now those costs are prohibitive, and they're really based on a per member per month pricing model that if you don't have the majority of your patients that are in a good payer panel incorporated in, it makes it very difficult to offset the cost for utilizing those analytics on your uninsured patients, because we want to make sure that any value-based care approach we have is multi-payer and can apply across the center and allow for the operations to follow suit. The other thing is that health information exchanges need to be supported. They need to have full visibility of all care interactions. We also need to incorporate telehealth and the provisions that were stood up during the public health emergency to make those permanent, because COVID really demonstrated that to be able to increase access and engage patients, telehealth is just really critical. The other thing that I would add is that there needs to be an effort around the integration of clinical and social data with inputs from the care team to utilize common race and ethnicity definitions, as well as SOGI data. And then to utilize a common set of social determinants of health screening measures. Also, incorporating closed route referrals can be difficult, but it can be essential, but it can be difficult on social service providers on the other end that are receiving these referrals, because they've got technological limitations that are far beyond the limitations that health care providers experienced even 20 years ago. So I think there's some steps that we have in an ideal world that we'd like to put into place. But I think we need to have clear-eyed recognition of the challenges that faces us and be able to put those resources to address those challenges accordingly.
Love that.
Absolutely. Well said, and great way to wrap us up. I will offer any last thoughts, comments, feedback from any of the speakers. I wish we had a couple more hours to talk about all of these things, but thank you.
I have a last comment.
Yes.
I just wanted to emphasize what we're aiming for in the HHS initiative to strengthen primary health care, and which is really ultimately probably the most important thing to accomplish is setting up that infrastructure at HHS for ongoing leadership and focus on primary health care. Since there are so many ways in which the federal government has a hand in shaping primary health care, what we need to do is bring those entities together that are doing the shaping with a shared goal and with leadership to really move the needle. But then at the same time, and this gets back to that coalition, there are other actors that need to be activated and recognize the potential and value of primary health care, and they need to be working concurrently with the federal government to move the needle.
Mm-hmm.
Absolutely.
And I would just say that the fee-for-service model as it currently exists simply does not align with our equity objectives. Value-based care will allow health centers to focus longitudinally on patient outcomes and the upstream impacts on health that occur outside of the exam room. As in other countries that have better health outcomes and lower per capita spending on health, primary care with a value-based approach should be a foundational service available to all. Community health centers are well positioned to serve as that national undergirding to such an approach, and we really look forward to partnering with you on this effort.
Thank you.
And I'll just close by saying, you know, as a family physician and just truly invested in really serving our communities, I just really believe that we as a nation need to take this sense of urgency now that has been displayed throughout this pandemic. We all knew way before the pandemic, but at least it's on people's radar now of how we're really going to address outcomes, not just process, but outcomes with regard to marginalized communities facing disparities. I think that we as a health system need to work together, have these collaborations, have these conversations, and we need to continue to bring down the silos. We need to work cross-specialty, cross-discipline in every sort of way. Medicine alone won't fix this. FQHCs alone won't fix this. Academic medical centers alone won't fix this. We are a larger health system in which we need to recognize that there is a larger population out there that is waiting for us. And we need to respond accordingly. And I'm just thankful, Judith, to your leadership in bringing this about through the government. It needs to start there. We have the grassroots. You have it in Ben's organizations there. We're all ready. We have amazing primary care clinicians around the country ready for this, but we're limited. And so it's really grateful for your leadership and the president's leadership in getting us there.
Agreed. Well, thank you so much to our panelists. Really appreciate the insights that you brought to this conversation and the work that you're doing, and definitely value what it is bringing to this summit and to our audience. So thank you so much for your time and your work.
Thank you.
Thank you.